All right, we'll get started. Welcome everyone to this ASSFN webinar for the mentorship committee. We want to thank Dr. Pilitzis for putting together this webinar. We have Dr. Jennifer Sweet, myself, and Dr. Jim McKinney for this webinar at 3 different talks. So we'll get started with Dr. Sweet talking about the indications for DBS and patient selection. Dr. Sweet, you let me know when you want me to change the slides. And for the participants, if you have any questions, please let us know. We can take the question depending on how many questions we have, either in the middle of the talk or towards the end.
Okay.
Dr. Sweet, you're on.
Sorry, I guess you couldn't hear me. Can you hear me now?
Yeah, we can hear you now. Yeah.
Okay, perfect. All right, well, thank you for having me, and hopefully this is of use to you. Do you mind going to the next slide? So mostly we're going to talk about indications for patient selection related to Parkinson's disease, as this is probably what you'll see most often for your DBS patients. So just a little bit of background. About 60,000 new cases of Parkinson's disease are diagnosed each year in the U.S. It affects about 1% of the population over the age of 50. There tends to be a slight male predominance, but no real social, ethnic, or geographic differences, and it's likely multifactorial. Can you go to the next slide? This is just a brief review, but we obviously know that the basal ganglia and cerebellum are going to be the primary players that influence the thalamus, and which influences the motor cortex and the output. So if you go to the next slide, that'll be mostly where our focus on modulating this disease is. So obviously the basal ganglia, you can go to the next slide. And traditionally we think of 2 primary pathways involved in Parkinson, the direct pathway and the indirect pathway, though there's likely also a hyperdirect pathway and other influences involved. And so the direct pathway, if you can go to the next slide, is responsible for really activating patient movement. And if you go 2 slides ahead, the indirect pathway plays a role in inhibiting movement. And if you go to the next slide, you can see that there is really this interplay between these pathways involved in Parkinson's disease, and it's the balance of these that that allow us to have normal function. Can you go to the next slide, please? And so dopamine has some receptors in both pathways, and in the direct pathway, the dopamine activates this system and leads to more movement, and in the indirect pathway, it inhibits it a little bit. Can you go forward again, please? And so when you have Parkinson's disease, you don't have enough of this direct pathway, and you have an overactivity of the indirect pathway, which is why patients tend to be stuck in their movements and have those slow movements. And you can go forward. And exogenous dopamine helps to restore this, but then if you go to the next slide, you see that too much dopamine can really affect it in the wrong direction, and you have overactivity of movement. Next slide, please. And so these are the systems that we primarily target with any of our neuromodulation for movement disorders, but primarily STN and GPI for the Parkinson's disease. Next slide. And so when you take exogenous dopamine early on in the disease, patients get this nice therapeutic benefit to the system, where you have really normal function, motor function primarily, each time that you take a dose. And then if you go to the next slide, you can see that later on in the disease, there's this imbalance where you tend to need more frequent dosing of medications, and also the highs and lows of the medications are a lot more severe, which can result in the dyskinesias and the bradykinias. Next slide. So in Parkinson's disease, there are obviously a lot of motor and non-motor symptoms involved. The ones in bold are primarily what we're going to be focusing on for the patient selection for Parkinson's disease. But tremor, rigidity, and bradykinesia are sort of those 3 cardinal motor symptoms that we aim to assess and improve. But patients will obviously have a lot of other symptoms: ataxia, they can have dysautonomia, they can have the shuffling gait and small handwriting, facial expressions are muted, hypophonia, And then there are also a lot of obviously non-motor symptoms. They can have cognitive decline, they can have depression, anxiety, they can have sleep disturbances, GI abnormalities. And so again, it's important to really assess all of these symptoms so that you know what the patient looks like overall and know which symptoms we're aiming to improve. Next slide. So for deep brain stimulation, our primary goals of therapy are going to be to improve the tremor, the bradykinesia, the rigidity, and then the dopamine-induced dyskinesia and motor fluctuations, as you saw from that earlier slide where the therapeutic benefit is limited over time. Next slide. And there is an extensive workup that's necessary for evaluating these patients to really ensure that we're going to be successful in our outcomes. And this is really important whenever you're establishing a practice anywhere, to assess all of these different areas and make sure that you have the right teammates to help you do this. So you're going to need a good movement disorder neurologist or group of neurologists. You're going to need to do levodopa response testing beforehand. The neurosurgeons will need to evaluate the patients, neuropsychologists, often a psychiatrist might be involved as well. And then you're going to need some imaging and your standard medical clearance. And all of this will sort of be discussed together at a multidisciplinary conference, ideally before implanting patients. If you go to the next slide, we can talk more about these. So in terms of the neurologic clearance, what are we really looking for? First, the neurologists really want to assess the symptoms and make sure that this is idiopathic Parkinson's disease. We want to make sure that this isn't Parkinsonism, because obviously the Parkinsonism symptoms are going to be poorly respondent to any therapies with surgical intervention. So it's really important to tease out all the symptoms, the course of the illness, the rate at which the illness progresses, to really ensure that this is a true idiopathic Parkinson's disease. Also, you want to start to target patients when they're no longer responsive to medications, or when they start to notice motor fluctuations with the medications, or they're taking a lot higher dosing or more frequent dosing, or they're on a high dose plan that you know will ultimately lead to these motor fluctuations. In terms of the levodopa response test, we typically want to see about a 30% decrease in symptoms. So what will happen is the neurologist will bring in these patients, they'll stop their medications at least 12 hours prior to being there, and they'll be evaluated with a UPDRS score. The UPDRS-3 is the motor score that will be assessed, and then they'll get a set of symptoms without medicines, and then they'll get a nice hefty dose of medications and reassess these patients. And we should see a 30% improvement with this medication dose. The exception to this is if patients have a very severe tremor. Since tremor doesn't always respond to the medications, then sometimes less than a 30% decrease will be acceptable, provided they have a very large tremor component to their symptoms. For neurosurgical clearance, we want to look for those cardinal motor symptoms, the rigidity, the bradykinesia, and the tremor. And the tremor can be action or resting. But it's important that those are going to be at least one of those symptoms is going to be a predominant symptom for the patient, and or the motor fluctuation with the medicines. The surgical risk will obviously be addressed. Age is something that we talk about for other surgeries, but for Parkinson patients, it's really not going to be as much of an issue. These patients are probably going to be older. We often operate in patients who are in their 70s or 80s, and a lot of that will just depend on the patient's overall level of function, their quality of life, and many patients really don't want to live any longer if their symptoms are truly debilitating. And so it's important to have those conversations with patients. Can you go to the next slide, please? For the neuropsychology clearance, we want to make sure that there's no significant cognitive deficits or dementia. So dementia is really an absolute contraindication to surgery, and worrisome scores would be less than a 26 on the mini mental exam or less than 123 on the dementia rating scale. So these are important to evaluate, and that you have a really good neuropsychologist who can help you with this. In addition, the neuropsychologist will often identify significant psychiatric concerns. And if there is a severe depression or anxiety, many of these concerns will need to be addressed prior to surgery to ensure a good outcome. So we'll often need to send those patients to a psychiatrist separately. MRI clearance, you want to make sure there are no structural abnormalities, and that the movement is appropriate. So there's not too much movement on the MRI so that you can do your surgical targeting. And then this is, I think, one of the most important things is that you want to really address expectations with patients. If a patient has severe trouble walking, you want to be able to assess why that is. Is it because they have ataxia? Is it because they have dysautonomia or the orthostatic hypotension? Is it because they have rigidity or bradykinesia? Some of those symptoms you're going to be able to help, which would improve their gait, and some of them you aren't going to be able to help. And so if a patient comes in and they say, you know, their primary goal for surgery is to improve their imbalance or their unsteady gait, you really need to have an important discussion with the patient to tell them which symptoms you'll be able to help and which ones you won't. And then finally, it's good to have a strong social support network for those patients. And so often if I go through this with a patient and they don't have any family with them, we'll advise them to maybe come back with their family or at least have a family conference call beforehand. Next slide, please. In terms of the timing of surgery, this is the last slide here. So typically we say that we like to see the disease for about 5 years. This tends to be when you start to see motor fluctuations or side effects from the medications over time. This is changing a little bit now with certain medications like Ritari, which is prolonging some of the medication course for some patients. But typically we do want to see some progression of the disease and less of a response with the medicines. We talk about this window of opportunity. So DBS too early in the course of the disease can expose patients unnecessarily to any surgical risks. And they might not be bothered by their motor symptoms of the disease at this point. And if you wait too long, then you might have progression of the cognitive decline or other symptoms that might not improve as much with the DBS. So it's really important to find that optimal time for patients. And then if you go to the last slide, just summarizing everything. So we know that this disease affects the motor and non-motor symptoms. It's really good. DBS is really good for the 3 cardinal symptoms: tremor, bradykinesia, and rigidity, and also any medication-induced motor fluctuations and/or dyskinesias. It's very important to have a really thorough multidisciplinary evaluation for patients beforehand and to make sure that you're on the same page as your referring physicians, your neurologists, and everybody involved. And then the timing of DBS is going to help you to really optimize the outcomes for patients. Thank you.
Thank you, Dr. Sweet. That was a very comprehensive overview. We'll take questions for Dr. Sweet, and you can raise your hand in the screen for the app. That way I'll be able to know who has a question and we'll be able to ask questions here. I'll start off with the first question. So I wanted to ask you, do you discuss the target for the DBS in your multidisciplinary meeting?
Yes, actually, that's a great question. We do that every time. We talk about the target, and now we're also adding into our conference which type of device we want to use, whether it's the directional leads or the conventional Medtronic leads or what, because and we also decide if we want to do it asleep versus awake because we do both techniques at our hospital now. So we have these discussions with each other, and we also have I have these conversations with the patients and let them all know thoroughly that there are lots of ways to do these surgeries. There are lots of devices now, and that why we would go towards one system or approach versus another.
Great. Dr. Pilitzis has a question. Dr. Pilitzis, go ahead, please. Dr. Pilitzis?
I think your computer is muted.
Can you?
Yeah, we can hear you.
Can you hear me now?
Yeah.
Oh, sorry about that. How do you decide whether you're going to do a patient asleep or awake, and then how do you decide which device you're going to use?
That's a good question. So it's in part neurology and neurosurgeon dependent. So we are now, most of our team is leaning more and more towards a sleep surgery. At this point, we have just found that to be a great way of doing it in our hands at our institution. One of the neurologists does like to test the patient with certain systems. So we tend to wake up one of the patients and we'll do sort of a hybrid. We won't use MER, but we'll do an awake testing with the lead in place just to ensure that we're happy. And we tend to do that more so with the tremor than with the other targets. Occasionally for the STN, we don't usually do it for GPI. And so when we do that hybrid awake system, it's really just to make sure that we feel comfortable with it. We rarely move it. And then it also helps a little bit with programming for that neurologist so he knows what to expect. And what was, I'm sorry, the second question about target?
Which device?
Oh, which device? So again, this tends to be the way that we're doing it. We are switching we're switching quite a bit now to the directional steering leads now that they have MRI compatibility. I think that there are a lot of benefits with this technology now. And so I think once in a while, if a patient, I guess if there's a really big concern that they're going to need extensive MRIs or something like that, then the Medtronic might be a good option. If it's GPI, then maybe sometimes we'll do those more with Medtronic or with either device, just because it's a little bit more of a forgiving area, I guess, or a larger target there. But for the most part, we're going mostly to the directional leads. And the question is really going to be when your third, now that there's a third player on the market, we're going to be starting to use those as well. And so I think it's just important to have the conversation with the neurologist. So we do this very openly with the neurologist. And then once we decide what our target is and what our lead is, we have these conversations with patients as well.
Awesome. I'd like to highlight that awake MER guided DBS is the on-label use, asleep DBS is the off-label technically, so that the trainees know. So Michael has a question. Michael, go ahead, please.
Yeah, hi, Dr. Sweet. I just had a quick question about the selection related to cognition. You had mentioned that MSC 26 is kind of the worrisome cutoff. I wonder when you consider for somebody maybe with more tremor predominant Parkinson's, kind of like caregiver fatigue and nursing homes, just a quality of life such that they can able to feed themselves, dress themselves. Do you accept a lower cognitive threshold rather to enable them to have even kind of more basic quality of life?
That's a great question, Mike. I think that, yes, is that in our practice, that's what we do. There have been certain cases, even with a 91-year-old man, where we really discussed with him that this is a palliative type of procedure. Some of these patients are just caregiver fatigue, but also patient fatigue. I mean, they're exhausted, and a lot of them have depression, and they really don't want to go on much longer with such severe symptoms. They are aware of the risks in those cases, and they're aware of the potential worsening of cognitive decline. But in those situations, we'll have extensive open conversations with the patients and their family. And I think that's really honestly important for everything. You just really want to manage expectations for everybody, the patients and the family. And we'll tell them that this is palliative, and many times we proceed forward. And in those situations as well, you can consider maybe doing one side versus both sides, although in Parkinson, we tend to do both sides at our institution. And you can also, those might be more situations where we would favor just doing it asleep just to make it easier for the patient. But we've had really good outcomes in those patients.
One more quick question I have for you, Dr. Sweet, is for your assessment, how much time do you keep? Do you see these patients for an hour, half an hour? What's your time?
That's a really great question. I'm a very bad business model for the hospital, and for a lot of people, I probably lose a lot of money for hospitals in that respect, because I do spend quite a bit of time. So my Parkinson patients, I tend to spend, I book 45 minutes with these patients, and I usually use the whole 45 minutes and sometimes even more. But I just think it's really important to address all of their medical systems. You know, they have a lot of other healthcare issues. They have a lot of questions. And this has been a really long process for these patients. So I want to make sure by the time we see them and by the time we implant that they're going to do well, and they're going to, know what to expect and not have any surprises, really. So I spend quite a bit of time. What about you guys? Do you spend that much time?
Yeah, I just wanted to highlight it as people in training go to their practices, they may have these different pressures about the time. And then people would say to you that these patients have already seen neurology. You just have to make sure that everything is okay and go on. But as Dr. Sweet mentioned, it takes a lot of time. These patients are older patients. Some of them have cognitive problems, And the range of issues that you have to discuss with them is quite broad. So it may take you 45 minutes to an hour, and I take an hour, and I'll agree with you, Dr. Sweet. It takes me full hour, and at the end of that hour, I feel satisfied and the patient feels satisfied, and there are no surprises on the day of surgery. And so,
Exactly. Great point.
we have two more questions, but in the sake of time, what we'll do is we'll move on to the next talk, but I'll encourage you to keep your questions. We'll discuss that at the end. We have some dedicated time at the end, and then we'll address those questions as we go along.
Great.
So the second talk is about avoiding complications and how I do it kind of format for this. And so there are three things I wanted to discuss in this: the general outline, what are the different targets, and what's the rationale behind stage DBS, what kind of a team do you need in the operating room, what are the goals of your surgery, and two different kinds of surgeries that Dr. Sweet mentioned to you, awake MER guided, and then MR guided or image guided broader surgery people even use intraoperative CT. Some of the immediate complications and how to avoid it: intracranial hemorrhage, inaccurate placement, and systemic issues that come with treating older patients who have neurodegenerative disorders. And in delayed phase, things like infection, lead migration, and exposed hardware as well. And so the DBS targets for Parkinson's disease, we have targets STN, GPI, and VIM for tremor dominant PD. For ET, the on-label use is unilateral VIM. Dystonia, bilateral GPI, and OCD is also approved for bilateral anterior limb of internal capsule through HDE. So staged DBS procedure, folks ask, what's the rationale for doing staged procedure? Sometimes patients present with hemibody symptoms, and so they have a lot of disease on one side, and the other side is relatively intact. So that may be an indication. Disease specific, for ET, the on-label use is unilateral VIM DBS. I know a lot of practices around the country even implant bilateral, either staged bilateral or even in the same setting, but the FDA approved indication is unilateral VIM. And then there are risks associated with different surgical targets. So STN has been described to have cognitive kind of side effects. VIM, more like difficulty with swallowing, difficulty speech with bilateral procedures, so something to keep in mind. And then accuracy of targeting looks like that the second side that we do surgery tends to have slightly more variability in terms of placement. And this variability may be a predictor of outcomes as well. So something to keep in your mind when you're doing the second side surgery in a bilateral procedure as well. The team that we need in the operating room, of course, in the neurosurgery team, you have attending neurosurgeon, trainees, residents, and fellows, scrub, the circulating nurse. In the neurology team, I still, I'm really insistent that the neurologist attend the cases. And the reason for that is they help me quite a bit with intraoperative testing. I'm heavily involved with that, but certain times there are side effects that are difficult to tease out. For example, is your patient having contractions or are they having dyskinesias? And what are the exact thresholds? And those are the sort of finer testing details that a trained neurologist can really help you in getting a precise placement. And then neurologists have seen these patients for a long time, so they know these people. And so reassuring patient during an awake craniotomy can come in very handy sometimes when the patients are having a hard time. And neurophysiology for interpreting and helping you with the microelectrode recording, figuring out the somatotopy and the functional domains within these nuclei. And we'll talk about that in the next slide as well. And anesthesiology team basically to manage the sedation and when to wake up the patient and managing your blood pressure and other vitals as well. So when we think about DBS, the goals of operation are define the boundaries of the nucleus, the boundaries in terms of the proximal and the distal border. For example, for STN placement, you want to look for SNR, which is the distal border. You want to look for the silent white matter zone above the STN. Or in VIM surgery, people talk about mapping the VIM-VC border. In GPI surgery, it's about mapping the optic tract for the distal border of your ventral lateral GPI. And then within the nucleus, trying to define the functional domains, the motor subdivision by looking at kinesthetic cells, tremor cells, beta oscillations. All of these point towards the motor domain within a nucleus. And then looking at the somatotopy, proximal versus distal, face versus hand, and these kind of different body part representations in the nucleus. And finally, at the end of the surgery, we want to know what's the therapeutic window. And therapeutic window is defined by looking at the threshold voltage amplitude that you need for getting efficacy and the threshold that causes side effects. So the difference between the two gives you a therapeutic window. And the side effects could be a variety of different side effects: motor side effects, sensory, eye deviations, mood. And so that allows you to understand how much room do you have in future to go up on the voltage without causing side effects. And so that it gives you sort of an idea 5 to 10 years down the lane, how much you can crank up on the DBS to get effective stimulation in future. I can take a question or two if you guys have a question or two before we move on to the next part of the talk. I see that Rao has a question. Rao, you want to go ahead? Rao, are you able to listen to me?
Yeah, sure, thanks. My question was, it came up actually from Dr. Sweet's part, but I'd love to hear all of your opinions. Talking about target selection for PD, do you have an opinion on which target you find more effective for dyskinesias? I've read and heard sort of variable things. And initially I thought they were roughly equally efficacious, but I've sort of read different things. So I'm curious to know what you think.
So in general, dyskinesias, the GPI target has been defined for better control of dyskinesias.
Okay.
But with ST and DBS as well, the major improvement in dyskinesia could come from reduction in medication. You could reduce medications by ST and DBS in the range of 40 to 60%. And so by reducing medications, you can allow for better control of dyskinesia as well. So that's sort of an indirect benefit of ST and DBS. So that's my answer. Dr. Sweet, Dr. Pilitsis, you have insights in this?
We're the same as you. I mean, typically these patients are going to have dyskinesias induced by their medications. And so the goal would be to reduce their medications so that you can reduce the motor fluctuations and such. But, there is a theoretically increased risk of having dyskinesias if you go into the STN. And so if you're truly worried about just that, then you may want to target GPI.
That's great insight, that if you're worried about dyskinesias, then GPI may be your target. So looks like Michael has a question as well. Michael, go ahead.
My hand might still be up from the last one. I should probably take it down.
Okay, good. So we move on to the next slide then. So when we think about stereotactic targeting, there are a variety of different ways where you target. So indirect targeting, where you use coordinates based on some internal landmarks, is the conventionally described targeting method. So with STN, people talk about 12, 4, 4. And so X, Y, Z coordinates, 12 from midline, and then in relation to STN is in relation to MCP, and then 4 below is in relation to the MCP coordinate as well. GPI is more, is also the Y coordinate is in relation to MCP, it's more lateral, 21 millimeter from midline. VIM is 10 millimeters from the ventricle wall, or people talk about, from the midline, but the midline coordinate can be problematic because patients tend to have atrophy and their third ventricle may be ballooned out. And then the Y coordinate is in relation to the PC, and so it's about 25% of ACPC length and at the ACPC plane. So in this day and age, when we have excellent imaging, the coordinates are mainly to help you just understand in the context that the the targeting that you're doing, is it within the framework or within the ballpark of what is conventionally advised? Most of us don't really follow these formulas. These help us to really make sure that we are not way off in our targeting. With imaging, we are able to look at some of these nuclei. And so for STN targeting, there are sequences described SWI and T2, and merging these sequences and playing with the grayscale or even heat or the color maps can help you visualize STN. GPI, there's a sequence described from University of Florida. The F-Gator sequence helps you to really look at the laminae and the GPI, and even within the GPI, the GPII part of the GPI for targeting. And then more recently, people have looked at ways of harnessing, say, tractography for targeting and atlas-based targeting as well. And tractography-based targeting is one of my areas of interest that I'll talk about in the next few slides as well. The Awake DBS, MER guided DBS is the FDA approved indication. So that's the on label. So I'll describe to you the method for that. So the process starts with placing the head frame. Some folks place the head frame in the pre-op area, but most of us place the head frame in the operating room with some sedation on board, local anesthetic at the pin sites. And then patient undergoes some type of volumetric acquisition with the frame in place. And then you do your targeting. And once the targeting is done, we prep and drape, open up the skin, drill the burr hole, and assemble the frame again and put the frame to the desired coordinates and lower the microelectrode recording device and perform the testing. This is followed by confirmation of the target and finally placement of the DBS lead. So this is the overall process. And depending on your workflow, from frame placement to DBS lead placement, it varies somewhere between 2.5 to 4.5 hours in terms of the overall procedure. Dr. Sweet talked about a sleep DBS. In our practice, a sleep DBS is mainly reserved for patients who cannot tolerate awake DBS for medical reasons. For example, patients have unilateral vocal cord paralysis. They have anxiety or claustrophobia associated. They cannot tolerate or don't want to have awake DBS. And so for these, we require some dedicated imaging to really make sure that the target that we are trying to aim, we are able to aim that. And so we use tractography for these patients. And the rationale for tractography comes from this age-old knowledge that has been passed to us from our mentors who described and for us that there are areas that are efficacious. For example, for tremor surgery, VIM is an efficacious region. But right next to those efficacious regions are the tracts that can give you side effects. For example, internal capsule, pyramidal tract, right lateral to the VIM, and posteriorly is the sensory nucleus. And so using this knowledge, we are able to visualize these fibers using tractography, some standard acquisition protocols, and able to resolve the neighboring anatomy of the VIM region and be able to visualize this for tremor surgery. And so we have used this for tremor surgery asleep as well. Now, the next phase of the talk is about avoiding complications. And so if someone has any question, I'm happy to take one question at this stage. If not, then we'll quickly move on to the next stage. So I don't see any question at this stage. So we'll move on to the next stage. So the next stage is about avoiding complications and how we can do that surgically. So intracranial hemorrhage is one of the dreaded complications for DBS surgery. And the process of avoiding intracranial hemorrhage starts with pre-op assessment, making sure that anticoagulation medications are off, patients don't have bleeding disorders, and all of us obtain contrast MRI to look at the blood vessels, especially venous structures next to the ventricles, and avoid those in our targeting. During surgery, we are very careful about blood pressure management and very diligent about hemostasis, epidural hemostasis, dura, PR echinoid. And then at the time of cannula insertion, we are very slow, and there are twisting movements of the cannula, you irrigate and make sure that insertion itself is not causing trauma. Postoperatively, we are again careful about managing the blood pressure, not letting blood pressure peak, and then also do surveillance imaging to pick up any immediate complications as well. Inaccuracy of electrode placement is another one of the dreaded complications. And the avoidance of this really starts by being very cautious about coordinates and checking these coordinates and doing an independent confirmation. You look at the coordinates, someone from your team, like a neurophysiologist or neurologist, looks at the team. And one way to check the coordinates is to actually measure it on the frame without looking at what the exact coordinates are, because we have a confirmation bias where if you know the coordinates, you tend to confirm that on the frame. So look at the frame and then confirm it with the planning coordinates. And then there are several sort of steps before you take a break and say, okay, what are my coordinates and are the coordinates accurate? For example, before you drill a burr hole or before you insert the cannula. And then during surgery, avoid intracranial shift by minimizing your dural opening, avoiding CSF egress, and then making sure that the trajectory and the cannula are cleared from any of the burr hole edges. You might have to undercut using the Carrison punch, and use intraoperative imaging. Most of us use fluoroscopy, but a lot of centers are using intraoperative CT as well. And when we do MR-guided procedures, again, we are checking the accuracy with intraoperative imaging. And finally, as we start our practices and as we get used to our equipment, all of us should be very careful in merging our postoperative CTs and making sure that our targeting is on point. Sometimes you would have frames that have sort of biases or medial trajectory placement, and so we have to be cognizant of that. And then there are some side effects related to surgical procedure itself, and the patients can have delirium, anxiety, and so using anesthesia partners during the surgery is of tremendous help. Urinary retention, and so avoiding anticholinergic medications and using catheters only when they are necessary can be a way to address those. I wanted to just quickly go over, a situation if you were to encounter poor microelectrode recordings. What do you do, if you're not having good recordings? So those could come from hardware-related issues. So check your impedances, making sure that all the electrode connections are okay. And then make sure that the electrode is actually coming out of the cannula and able to record in the brain tissue. And so fluoroscopy may be a good way to check that. Then there are patient-related factors. They could be too sedated. Their eyes could be closed. Or the anesthesia team ended up in giving some beta blockers.
Hey,
Or
Stevie, have some salt.
I'm sorry? Or the blood pressure may be a problem, so check the vitals. And then finally, these could be related to the anatomy. You may be recording in the white matter or a perivascular space. So these are the sort of anatomical consideration that should come in your mind. And finally, in the operating room, there are so many sources of interference, including the electronics. For example, overhead lights can be a common source of interference. And so checking those would be another way. As far as delayed complications go, infection is a common one. And so again, making sure that your patient's diabetes is under control, check their hemoglobin A1C, MRSA screen, dental hygiene, nutritional status. During surgery, preoperative antibiotics, very diligent layered wound closure, and postoperatively monitoring the wound and making sure that patients are not doing procedures that may cause bacterial contaminations immediately afterwards could be ways to avoid some of these infection complications. Lead migration is another complication that we worry about, and there are certain steps that we can do where we try to keep the junction of intracranial lead and the extension above the mastoid. We tack the IPG to the underlying pectoralis fascia or to the clavicle, use the Stimlock device to avoid migration. And then there are certain things that all of us do in different flavors. For example, we request the patient to avoid sternus activities 4 to 6 weeks after surgery. And then we obtain immediate postoperative X-rays that allow us to follow over time where these leads may be in case there is a problem that arises. if you unfortunately end up in encountering exposed hardware, and in some of these patients you do, because as Parkinson's disease progresses, their nutritional status goes down and it becomes a challenge. And so immediate intervention is the dictum. We try to save the intracranial lead. You remove as much hardware as is exposed, intravenous antibiotics, ID consult, and reimplantation if and when indicated is the way to go. So this was my last slide. I'm happy to take any questions from the participants. So I'm going to check if you have questions. While I load the next presentation, please let us know if you have any questions there. So I don't see any hand for questions. So what we'll do is we will move on to the next talk. So Dr. McInerney, you are on, sir.
Okay. Can you all hear me? Okay. Thanks for having me. I get to do the boring stuff, I think. This is mostly about building a practice. You know, in terms of thinking about broadly a stereotactic and functional practice, obviously doesn't just include movement disorders or just Parkinson's disease. It includes a lot of other things potentially as well, and I think we all do different things in order to, you know, basically make a living. But I think what you'll see and the things that I talk about here should actually be applicable for virtually all of these things that most of us do. So if I can have the next slide. I think one of the things about a stereotactic and functional practice that kind of sets us apart from some of the other neurosurgical practices is the fact that we have to be collaborative, we have to cooperate, and we really have to place a huge emphasis on communication in terms of building our practices. Our practices don't happen without the help, unfortunately, of other specialties and other colleagues, among them people like movement disorder neurologists that we've talked about, or, you know, pain management, epileptologists, radiation oncologists, and the like. And at the end of the day, you have to be, you know, the trunk of the tree for that program. And, you know, individual branches don't work very well without a trunk. But by the same token, one of the things I always say is that if you do the right thing, success will follow. And if you take care of your patients, what you find in my experience, at least, is that the movement disorder neurologists and everybody else come to you because you become a real resource for them. You have the potential to make their patients really legitimately better than almost anything else they can do. And if you do a good job with that, everything else will fall into place. Okay, the next slide. So this is just the why should you listen to me slide, I guess I would say, is sort of a very open and transparent look at how many DBS implants we've done over the years. This just only goes up to 2015. You give me the next slide. This is just a graph to kind of visualize what that looks like. We've continued up from there, and I think I just finished up my, by my count, 659th implant a few minutes ago. And so, you know, that kind of growth is something that I think is, you know, it's not special to me per se. It's the work of hard work of an awful lot of people, and you know, it comes from the support of your institution and also, you know, how good the area that you find yourself is in terms of competition and other things. There's a lot of little details that go into this kind of stuff. If I can have the next slide. But I think, you know, from your own perspective in terms of building a practice, there are some things that you have to really keep a close eye on. And your clinical mission, in my mind, includes really all of these 5 areas: quality, access, productivity, marketing, and resources. And I'm going to go through each of those things, but just briefly, you want to improve and you want to document the quality of the care that you're giving to your patients, and make sure you pay close attention to patient satisfaction, because as I'm going to talk about, a lot of this is spread word of mouth. Access is incredibly important. It is really, you have to be available to your patients. This is an elective procedure. If you're not available to them, they'll go someplace else. Productivity is really important. You have to constantly work to improve the efficiency of your care so that you can take care of more people. As you get busier, this becomes an even bigger priority. And along the way, you have to conserve resources and maximize your revenues to the extent that you can. I think a lot of times people will say that deep brain stimulation especially is not particularly a moneymaker in an institution. And while from an RVU perspective, that's often true, on the hospital side, that actually often is not true. That's why they let us do what we do, because we actually can, under a lot of circumstances, especially if you pay attention to it, maximize revenues. The marketing, how do you communicate your services not only to patients, but to your physician colleagues? And then finally, what are the resources you need to carry out all of these other things? So if I can have the next slide. So when we talk about quality, I said you have to improve and document the quality of care and patient satisfaction. The bullet points here, you got to really make your patients and their outcomes your top priority. And you have to track those outcomes very closely. We've done that by creating a prospective registry. We've now at this point are starting to take that national. I think, without being able to pay attention to what we do well and what we can do better, we wouldn't be able to tell people and answer the questions that they have. They come to us with very specific questions sometimes about, well, how am I going to do? And you should be able to answer that, and not just answer it based off of the literature, but off of your own experience eventually. We do quality assurance and quality improvement projects all the time, and we've over the years looked at things like age, infection, cognitive outcomes, and accuracy. And I'll just go ahead and since those things came up in the other talks, I'll use this to put out some of my not so conventional wisdom views on these things. Age, we learned early on, didn't make a difference. We found that patients over 70 come in a little bit worse and go out a little bit worse. But when you look at the improvement they make, it's actually very similar to the improvement that patients under 70 make. So really no difference there. Infections, we found one of the things we learned over the years is that if we simply do a wound revision at the first sign of an infection, we actually can salvage the hardware in 60% of the cases that we've done. And so that's become part of our routine. We don't routinely explant devices if there's a wound infection, but we'll do a wound revision as a first step after some antibiotics usually. And between those two things, we'll usually, more often than not, be able to salvage the hardware. So that's actually ends up being a huge patient satisfier because they never lose their stimulation if you're able to do that. Cognitive outcomes, there's a lot of talk about cognitive problems in Parkinson's disease. Our reviews of the literature and our own patients show that the biggest cognitive problem that Parkinson's patients have is with verbal fluency. Well, I think we all know that Parkinson's patients have speech as one of their many most significant symptoms, and one that we often don't improve with our stimulators, unfortunately. And so if that's the biggest reason that they're getting graded down on their cognitive performance, then it might be that cognitive declines are not as much of a problem as we've once thought. And we've really taken to looking at our cognitive evaluations more as a look to how much resources are you going to need afterwards than as a strict method for eliminating patients as candidates. And in fact, some of our patients who have had cognitive problems and hallucinations have been some of our best success stories. And then accuracy, we went away from the frame-based, classical frame-based system to the StarFix system over 10 years ago now, in part because we found that our accuracy was better using that system, and we found that our efficiency was improved as well. So long way of saying that, there's a lot of detail that you can look at and actually, a lot of things that you can improve, and doing that is the kind of thing that makes people come to you. Good communication is a key to patient satisfaction. All of those things are things that we talk about, and we talk about it with them in depth. We talked before about how much time you spend with a patient. I'm going to get into this again in a minute, but I've taken now to we do an intake session with all the patients, telling them all of the things that are common to all DBS patients in a group, and then go over their individual questions with them privately. So if I can have the next slide. Improving patient access. This is, I think this you would think should be probably self-evident, But it really it can be a challenge at times. You have busy practices, and especially if you're new in practice, you have a lot of pressure to produce, and you're probably not going to have 50 DBS patients the first week. But overall, growth of the DBS as a service has been patient-driven, and so it's really important to get patients in so you can see them when they have questions. And when I first started, I mean, I just, even if they just had Parkinson's disease, I would see them, even for whatever questions they might have, because if you don't talk to them, you can't ever operate on them. We took to setting up dedicated patient slots to make sure that they would always get in. And often big busy programs will have a large efficient movement disorder neurology program that is feeding a movement disorder functional neurosurgeon, but that's not always the case. It's nice if you can do that, and we've done that now, but it's not actually how we started. Now we do have a multidisciplinary clinic, and that's when we do patient intake, we'll have several patients come in, and like I said, I'll give them a talk about what DBS entails and what it's all about. And that usually takes about 45 minutes to an hour. And then afterwards, we put everybody in one room, and then we go and see them ourselves rather than give them, some bizarre, treasure hunt all over the medical complex trying to find all their various subspecialists. In that multidisciplinary clinic, they get to see the movement disorder neurologist, one of my nurses who goes over some of the nuts and bolts of the procedure with them and what to expect. They get to see the neuropsychologist. They get to see a physical therapist, usually, especially if they have Parkinson's disease. Sometimes they'll get to see the speech therapist. And obviously they get to see me, and I try and do that at the end so that we can go over all the questions that they have. But I did say that that's not how we started. We started by reaching out directly to community referral sources, and these can be really, really good partners, especially early on. There's an awful lot of people out there who are looking to be involved in this kind of thing, and it can be very rewarding on their end as well. And one of the things that we learned over time is that if we can implant somebody and get them back to their neurologist, so that especially if we've already done their initial programming, that's the kind of thing that makes a neurologist, a skeptical neurologist, into a convert and even an enthusiast many times. So if I can have the next slide. So as I was saying about the community referrals, I think it's really important to be prepared to meet the needs of your referring neurologists. Even 20 years after this therapy has been approved in this country, many of them are still in need of education, and many of them will appreciate collaboration. In terms of programming, some of them are going to be very hands-on and want to do that, and they deserve our respect if that's what they want. They can take a very dim view at times of you stealing their patient from them. Other times, they don't want to deal with it at all, and you're going to end up doing the programming, and you should be ready to have that service available to them. But as I said, my favorite is when we did the initial programming and then return them to them to manage. That usually works out best for a lot of people, including the patient themselves, perhaps most importantly, because they don't have to necessarily go quite as far. They can see the person that they've been seeing at home. So if I can have the next slide. So productivity, looking at the efficiency of your care and conserving resources, maximizing revenue. You want to be set up to maximize both clinical benefit and revenue. And so if you look at your program from an integrated standpoint, meaning how does the preoperative evaluation impact on the overall bottom line of the institution? Neuropsychology tests, physical therapy, evaluations, and other things are part of the workup and do get paid for. Programming by neurology, it can be a moneymaker. Actually, one of the few things in neurology sometimes that can be a moneymaker. And if you have a rehab institution associated with you in some way, that can be a huge benefit for patients postoperatively, both in terms of their overall outcomes and also the institution's bottom line. In addition, little things like scans and whether that you get for planning and whether or not they get paid for when you do a Starfix system, in part because you implant fiducials a week out or so for your planning, your scans get paid for. And if you look at those things, it becomes more clear to the institution that the bottom line actually is a lot better than they initially thought when they looked at it just in terms of, one implant procedure and a short post-operative stay. Can I have the next slide? So, as far as coding is concerned, most of this, falls under the 61867 code. And, I'm not the biggest coder, but I put this list of comorbidities up here because it's important. We look for these things all the time because if we can document any of these things, and my staff goes through the charts just in case this happens to be there someplace, you actually can pretty much double the amount of that a procedure will reimburse from Medicare and from most insurances because you're able to document comorbidities. I really hate doing things like this because it feels so much like you're playing a game. But as one of my mentors said a long time ago, if they're going to force you to play a game, may as well play it to win. And this is what they're willing to pay for. I think there are other things that are probably more important that they should pay for, but this will dramatically increase the bottom line of the program if you can identify these things when they're at play. Can I have the next slide? Marketing, as I said, informing both patients and referring physicians of your services. Word of mouth is by far the biggest thing, and all of our patients are our own little marketers because they are very, very interested in sharing their good fortune with their fellow patients and sufferers. One of the things that we've done is to try to be available for education, and so we do a monthly lunch and learn where we and it's free to the patients, so we have them sign up so that we can get enough food from Panera usually, and then they come and we just talk to them about what a DBS actually means. And what I tell the referring physicians is, please don't talk about it because they often start with, well, they're going to drill some holes in your head and they're going to put some wires in your brain, and that sounds pretty daunting and off-putting to an awful lot of people. And so over the years I've tried to gently encourage them not to talk about the procedure, especially if they don't really know it, and to just give them an invitation to come to one of our lunch and learns. There's no obligation, there's no charge. In fact, we're going to give you food, and people do anything for free food. That's since medical school, right? So and it works afterwards as well, and it works for patients too. And so just by doing that, we get a lot of education to our patients. Physicians are a little harder to get out. Usually takes a dinner rather than a sandwich, but still, I think there's nothing that beats going out and meeting a potential referral source. The industry reps, I think, would be very, very willing to help you arrange those kinds of things, and going out and meeting them and giving them a chance to get to know you and know, how well-meaning you are, how caring you are, how intelligent and hardworking you are, will just go, so many more miles than almost anything else you could do. I will say that media stories are always effective in the short run. We've done a bunch of them over the years. We've done print media stories. We've had magazines and newspaper stories. We've done individual TV news reports where we had people come to talk to us and even, record things in the OR. We are lucky in that one of our local television news stations likes to do a call-in show with us, and we'll do one of those every other year, which is about a half an hour time at about 7:30 in the evening, right about now. Really, we get hundreds of thousands of people watching those shows, and we get Nielsen ratings that actually tell us that. But they don't last. I think that's the bottom line, and so that's perhaps the advantage of a webinar like this, which is something else we've tried in the past, is that you can make it last a little bit longer because you can make it, memorialize it on the internet, and people can go and take a look at it any time. Although we've also put our call-in shows up on the internet as well. So those things are effective, and what they tend to do is give you a bolus that then, starts to go away over time. If I can have the next slide. So what do you need to be successful? What kind of resources do you need? I think the bottom line is you need personnel who are dedicated to the program. You have to build a team. You really do have to find the dedicated movement disorder neurologist, the social worker, the research coordinator, the coordination between services, neurology, rehab, psychiatry. I tell patients all the time that, I'm kind of a one-trick pony when it comes to Parkinson's disease or essential tremor or what have you. But the one thing I have learned is that if we don't pay attention to the details, then we don't get good outcomes. And even if I take care of 80% of it, if that last 20% isn't taken care of because they have depression and it's untreated, or they have a cognitive problem that's unaddressed, or they're still posturally unstable and we haven't sent them to physical therapy and taught them how to walk better now that they can move better, then we haven't done the whole job. And so it's really important to pay attention to those things in order to get that patient satisfaction up really high and to get the kind of outcomes that get your patients wanting to tell all their friends that they need to come see you as well. And can I have the next slide? So we've already talked about the team, and it's everybody, and you've seen all these people in your training and your practices, I'm sure. I think there's nobody on the list that isn't important, and it's really important to remember it's the knowledge, hard work, and dedication of all of these people working together that make you successful. And as you're building your team, it's always important, as I'm sure you're all aware, to thank them and to make them feel important, because people really do want to do something meaningful, and everybody who's involved in these programs, I think, realizes what a big difference they make in patients' lives. And when they feel like that's a big part of what they're doing, they'll work even harder for you, and that's really what you want, because ultimately we're all working for our patients, and we do a great thing for them, and it'd be great if we could do more. And so that's always, that's how you do it, is part by letting everybody know just how much you appreciate the work that they put in. So if I can have the next slide, I think I am done. So that's my tree, branches with a trunk, and that's how it works. And if you guys have any questions, I'm happy to take them.
That was an excellent talk. We finished on a high note. That was very good. Let's see if people have any questions here. I don't see any hands. You're welcome to ask a question or two, guys, if you want. Okay, so we have Ben. So let's see. Go ahead.
Hi, thank you very much. I was just curious how you practically obtain all the prospective data, who actually does that, and how it's organized at your institution.
At our institution, so so basically over the years it's grown. So it started with mostly just our neuropsychological data, and we put that into an Access database, and then from there it went into a REDCap database. Now it's gone into an even bigger database, and it includes UPDRS scores and everything else. But basically, the fundamental thing is to capture it at the time that you do it. And so as we're doing those things, as we're doing it in the OR, as we're doing it in the clinic, and all of that information, we put in at the moment, because if you don't do that, it's almost never going to get done. When we have fallen behind, I've usually been fortunate enough to get a research coordinator. Even after all these years, I still haven't gotten one regular research coordinator all the time. But occasionally I've had to have them go back and fill stuff in again. And we're starting to we've taken that concept so we've been working on this RAD-PD, Registry for the Advancement of DBS and Parkinson's Disease, which is a national registry that we've been rolling out with the Parkinson's Study Group and Michael J. Fox Foundation, which, if it grows the way we hope it does, will actually be a turnkey solution for that, where we actually can give you a registry type program where it actually improves your workflow, where you actually as you're seeing the patient, you can have your neurologist enter the UPDRS scores, and you can have your neuropsychologist enter their sort of standardized baseline cognitive and neuropsychological evaluations. So I think we all recognize it's a challenging job to do, but I think it's a really important job to do, because if you don't do it, you can't tell people how you're making them better.
Okay, Michael has a question. Go ahead, Mike.
Yes, thank you for the talk. I thought it was a very interesting point earlier on with quality assurance, quality improvement. You said up to 60% of your infections you're able to take back early, and you can salvage the hardware, because normally what I've seen, what is said in the literature, is that when you see eroded hardware or infection, people take it out, whether that's right or wrong. It's usually general practice. And I'm just wondering, is it simple erosion, erythema? Like, are you also salvaging purulence erosion?
Sure. Well, and I think we've looked at this a lot over the years because it's a very, very complicated question if you look at it in the literature. What people will call an infection are different things. And so the way I've chosen to look at it is, look, in your first 6 weeks, if you have wound breakdown, I don't know if it's infected or not. Sometimes we culture things, sometimes we don't. But the worst case scenario is that it's going to be infected, because once the skin is breached, you can be infected. And so we're very aggressive, I think, and that might be part of the reason why we've been successful at taking people back if we think that there's any kind of wound healing problem. But I can tell you that there have been plenty of times that we have seen pus and we have washed it out, cleaned it up, revised the wound, and we have been successful in getting them to heal. And again, more often than not. And it wasn't, I wasn't sure about that until, the real motivator to do it was the patients themselves, because they didn't want to lose their device. If you think about the timing of it, it's right after they've been initially programmed. They're just, after a huge amount of investment on their part and apprehension, now all of a sudden, they've seen the difference, they're feeling better, and you're telling them you're going to take it away because of this infection. So we tried, and we found out that we were being pretty successful. So we tried more, and over time we realized that we actually were 60% successful. So I realize it's not what it says in the literature, although we did have some minor publications on that, but people don't always like to publish the things that don't go along with what everybody else says. So, but that's been what we've seen. And so, in talking to people, I think a lot of people are willing to do wound revisions over time after they've gotten used to it. Early on in your practice, you just feel like you should take everything out, and that's probably a good idea in general. But after a while, it's just something that we've learned.
Thank you.
All right, one more question before we end the webinar. All right, I don't see any hands. All right, very good. Well, thank you all for attending. It was a very good webinar. Thank you, Dr. Pilitzis, again for putting it together. Thank you, Dr. Sweet and Dr. McKinney.
And thank you, Dr. Krishna, and thanks to all the mentees and some of the mentors that came. We'll see you in January, and make sure to contact your mentor for another phone call if you haven't done so this quarter. Okay, take care.
Bye.
Thank you.
Thanks. Bye-bye.